we are going to go into the lab and talk about multi-rod constructs. Been fortunate enough to see some very complex spine revisions in my training here at Swedish, and there are many different ways to approach a spinal fusion, and this is kind of one of our more traditional AIS cases. They do very well, not a big screw density, 2 rods, and they do great. Here's another approach to doing spinal fusion where we've got 2 ancillary rods connected by side-to-side connectors, providing a little bit of extra rigidity. And then here is one of the constructs we did here where we've got multiple iliac screws and multiple different planes of fixation going on, and these are usually done in cases where previous fixation has failed. So, and then, I found this one from a different physician, but again, the amount of different rods that people are trying to put into constructs is getting to be quite an impressive thing, and really not a whole lot of data out there. Some new data has come out. Most of the stuff has come out in the past couple of years, so I just wanted to review some of the literature. Some of our indications for it are 3-column osteotomies. This is where the majority of the literature is. We'll talk about it later. Tumor cases where you have a very unstable, maybe you're doing a corpectomy in the front and you have almost a full section with no anterior column stability, or very compromised because you're putting in an anterior cage, corpectomy cage. Those are cases where you might want to consider doing some extra fixation with more than just 2 rods. A number of cases that we've seen here in Charcot Arthropathy in patients that may be paraplegic because they have that very weak core strength, put a lot of stress across rods, and a lot of these failures can come at greater than 5 years out. So some may look very good over the first several years, but because they don't have enough core strength in their musculature, they can wear those rods out and they can break and fail. Neuromuscular deformities and severe osteoporosis are some other indications, a little bit less strong, but definitely can be helpful if you do need the extra fixation. Again, I said before, PSO is the one place where they've actually looked at it in a scientific manner, and not very many have long-term follow-up. So the first 2 that I'll look at are both in vitro studies, so they're models. This one was done with an L3 PSO, fixation from L1 to S1, and each construct was tested for mechanical strain. So the model, I didn't put a picture up here, but it was basically a PSO at L3, and then they tested 4 different, or several different fixation models. So this is, first they did the PSO, then they did titanium 2-rod, 4-rod, cobalt chrome 2 and 4, and then they actually put spacers above and below that PSO to try to see if the spacers above and below would add extra fixation. And they actually did show that significant, actually more than some, if you look on the right side over here, on the pointer, but yeah, if you look at the right side over here, cobalt chrome with 2 rods and spacers is actually stiffer than cobalt chrome 4 rods. So we usually don't think about the intervertebral spacer above and below as being a big additive to the stiffness of a construct, but it actually helps to stabilize that PSO and close it down and provide more stability at the point where you're trying to get the bones to heal. This is where they measured the actual surface strain, and kind of unsurprisingly, when you do add extra fixation to the construct, you have less strain against the individual rods. Sorry. And then this was actually a study just came out about a month ago where they did a similar study looking at 2-rod versus multi-rod constructs and looking at different orientations. So this was used as the control up here, kind of our typical 2-rod construct. This was a PSO that was created. And then these are kind of a more traditional, where some people will use 2 rods to fix right across the PSO site, and then do the longer rod across the entire construct. And then here is a longer accessory rod, and then, oops. And what they were really looking at is what they call a delta accessory rod, where this one from one side to the other, or 2 of them, or in one line. But if you look at it from in the sagittal plane from the lateral, it's actually out of phase with the normal contour. So rather than having lordosis bent into that rod, they use these to actually almost make like a kickstand, but in the sagittal plane, and to see if that was a more stable construct. Apparently they've had success with this in their clinical practice. A lot of numbers up here, but the big takeaway is that the delta type configuration with the 2 rods rather than just one from one side to the other were the strongest, both in terms of bending moment and in terms of the strain across the primary rods. So again, it's something that we usually don't think to do, is to put those accessory rods out of phase. And again, just want to show you here on the lateral that, this construct and this construct was fairly similar, and the take-home point was that this more direct line is a stronger support for the primary rod if you are going to be adding accessory rods to your construct. This was, again, looking at our PSOs. And this was 2-year follow-up. Mean was 7 years, minimum was 2 years for this. And this was a matched cohort study with the what we would call a quad rod, so 4 rods versus 2. And some of them were 3 rod constructs, but all of them multiple rods versus a standard 2 rod. And then looking at the number of pseudoarthroses, and again, these were not done with a CT scan, but only with plain radiographs, because that's what they had available. But half the rate of pseudoarthrosis in the group with the multi-rod construct. So those were the main significant findings, and none at the actual osteotomy site. So a lot of those pseudoarthroses were in different places besides where the osteotomy was. This is the last one here. Again, looking at preventing rod breakage and pseudoarthrosis in PSOs. This is for adult spinal deformity. Another single-center retrospective study with a minimum of 1-year follow-up. So again, not that long, fairly small study, 15 and 16 in the 2 groups, and they did use BMP in all these cases. These actually did show the pseudoarthroses using a CT scan, so probably a little bit more accurate than the previous study. But in all those L5S1 pseudoarthroses, and wait, this was actually a lumbosacral junction, so this was not with the PSO, I'm sorry, which is interesting because this is one of the only studies to look at multi-rods without a PSO. And again, that's the big take-home point here, multi-rod constructs, no rod fracture, and no pseudoarthroses. Last one here is just showing that you can have, breakage of the screws, of the pelvic screws, and another study, a little bit bigger, 55 and 51 in the multi-rod construct with a 42-month follow-up as a mean. No significantly different significance in ODI. But looking here at the bottom, when you're looking at the rod fracture, significantly more in the 2-rod group, but if you look at the screw loosening, significantly more in the multi-rod group. So knowing that, as we talked about before, you're kind of trading one complication for another. The stress across your construct, it has to go somewhere. So if the rod construct is stronger and you're placing it all on those 2 screws, you do put yourself at a little bit higher risk for screw fracture at the bottom of your construct. And when we're talking about here, there's lots of different ways to do these multi-rod constructs. Some, when you have modular screws, you can choose different places to place the dual heads. Some of the screws in the middle come with the pre-assembled, so you can use those, and you have to kind of pre-plan where you want to have your multiple rod constructs. And that provides a little bit stronger fixation, whereas the side-to-side connectors can also be used, give you a little bit more flexibility as to where you want to place them. And, we talked about this with tumor surgery, again, but it can also be true in big revisions or in infections where you have to have resection of that large anterior mass or infection, and just to be considerate of how much surgery you want to do in these patients, because if it's an older patient, if it's a palliative type procedure, then you really don't want to spend the extra time and do these big constructs for patients that are going to be kind of limited in their lifespan, and how much are you actually going to be doing for them. And so this was just kind of a schematic where you can show where you would plan this out ahead of time, where you want to place the dual rods. So here, this would be a very simple setup where if, for instance, you had a PSO at one of these levels, you could put the dual rods here, and then the longer rods across the entire construct, and it just gives you a lot more flexibility in terms of where you're going to put those connectors in. We have a few cases here, but I think we'll go forward to Basim's talk. We're going to talk a little bit about the literature, or the basically trying to create some names for these, because these are things that people are making up, and we really don't have a consensus on what words to use. They're kind of colloquial, kickstand, quad rod, things we basically all just made up. So we're going to present some of our own terminology and see if we can find something that we can all agree upon. So Basim, you ready? Maybe not. Yeah, these are just some of the cases that we've done. And again, multiple iliac screws. Again, we know good literature to say that it's any better, but if you are doing a multi-rod construct and you're putting more stress across those iliac screws, maybe 2 screws will be less likely to fail at the junction of the construct and the iliac screw interface. But again, no real good data to show that. And again, think about multi-rod constructs, and whenever you're taking away that anterior column, that's one of the major supports of a spinal construct when you're doing a reconstruction for whatever it is. So consider using it in your large revisions or when you feel like there won't be anterior stability. Often don't think about putting interbody spacers above and below a PSO, but there is some data now to show that that does create extra stability at that site. And then, again, consider your patient, balance your invasiveness with your the gain that you're going to be getting from that procedure.